Yes,
Hello.
sir.
Yeah,
We are
am I
live.
audible?
Yes, sir. You are audible.
Okay. Hello. Good
Hello.
afternoon, everybody. Am I audible?
Yes, sir. You are audible.
Okay. Okay. Great. Let me know when we can start. Okay.
Hi, Sudipta.
Hi. Hello. Hi. Hi, Dr. Tapas. Good
Hi.
afternoon.
Good afternoon. Good afternoon.
So, good afternoon, everybody, and welcome to today's session on nasal high flow or HFNC therapy inside and outside COVID-19. I would like to welcome you all on behalf of the organizer. I'd like to thank the organizer for inviting me and giving me the opportunity to make a presentation on this very relevant present topic. I'm myself Dr. Sudipta Mukherjee, consultant critical care medicine from Tata Medical Center, Calcutta, and, and along with me there is Dr. Tapas Sahoo from Medanta Ranchi, who will present another part of nasal high flow therapy after my presentation. Now, because of this COVID era, we are all are more or less familiar with this high flow nasal cannula or HFNC therapy, and it has a significant role in decreasing the intubation rate and managing the refractory hypoxemia that we are developing because of COVID-19. And in that regard, Dr. Tapas will talk on the role of hyflonasal cannula and other oxygen therapy in COVID-19 patients. And what I will do, I will take you all to the pre-COVID era, before COVID, where we are used to use HFNC in our regular practice in a certain subgroup of patients, and we'll try to discuss or share our perspective and our experience with this modality. So high flow nasal cannula is a very simple machine. It has a flow meter with an air oxygen blender. Here we can increase the oxygen concentration as high as 100%, nearly 100%. It has an active humidifier along with a heated inspiratory circuit. So whenever we are delivering the gas, it usually maintains optimal humidification and also the temperature. And at the end, the patient, there is a nasal cannula through which the gas is delivered. Now we all have used in our daily practice nasal cannula, and we nasal cannula we usually give up to 6 liter or to 4 to 6 liter of oxygen. But when you are talking about nasal cannula with very high flow, there are some drawbacks. Like there will be these are not optimally temperatured here. There is lack of humidification, and as a result, because of high flow, there will be mucosal injury. And along with that, because the flow is less than the inspiratory flow of the patient, there will be entrapment of air from the surrounding, causing a decrease in the FiO2. At least these three challenges has been taken care of by the HFNC when we have options to increase the flow as high as 60 liter, which will be covered most of the inspiratory effort and will be and the air will be optimally heated and humidified. So what will be the physiological effects? There will be high flow washout carbon dioxide in the anatomical dead space. All the dead space will be replaced by oxygen. Although they will be delivered through an open system, that is not a closed system, mouth, the air will be lost from the nasal cavity, nose, and also from the mouth. The high flow will overcome the resistance against the expiratory flow, and it will create a positive nasopharyngeal pressure. While the pressure is relatively low compared to the closed system, still it is considered to be adequate to increase the lung volume or recruit the collapsed alveoli. We'll look at the data or the practical experience. And the difference between the inspiratory flow and the patient and the delivered flow is small, and as a result, FiO2 is relatively constant. There is a very little amount of entrapment of air from the surrounding. And as this gas is generally heated up to 37 degrees centigrade and optimally humidified, there will be an optimal mucociliary function, and there will be very little discomfort to the patient even with such a high flow. What are the other physiological advantages? It will help in facilitate mucus clearance. It decreases the upper airway resistance, prevent upper airway collapse during inspiration, and also decrease the resistive work of breathing. And eventually, it will reduce the patient's breathing effort, which will be proved by the when you look at the pressure time product. So, what is the practical or clinical experience or clinical data we have? So, whenever we are using HFNC, we have used HFNC compared to oxygen face mask. We have found that because the work of breathing has decreased, the peak inspiratory pressure has decreased, there is a decrease in the esophageal pressure, and there is a decrease in the PTP, which is the pressure timed pressure. There will be a decrease in the dynamic changes in the end inspiratory transalveolar pressure, and all these things lead to decrease in the respiratory rate. And with the similar amount of the similar value of PCO2, PaCO2, and EtCO2, there will be a decrease in the minute ventilation. Eventually, all these things will cause improvement of PaO2, mean arterial pressure, they will decrease the heart rate, and all those things will improve the overall condition or comfort of the patient. And if you look at the PaO2 compared to the same FiO2, and we will compare with a nasal cannula with a supplemental oxygen, HFNC usually gives a higher PO2, and at the same time it maintains optimal carbon dioxide. As a result, there will be decrease in the minute ventilation of the patient and the total overall work of breathing, because the washout of the carbon dioxide is much better compared to a mask. And what are the other physiological changes? There will be improvement in the end expiratory lung impedance. There will be a better lung aeration in terms of homogeneity and the respiratory pattern because of this high flow. And as a result, the general global inhomogeneity index will go down. Peak inspiratory flow, peak expiratory flow, both in the dependent and also in the global area will be optimized, it will decrease. All these things lead to a overall physiological improvement of the respiratory parameters. So now we'll see in a practical scenario, in a case-based scenario, how we can utilize it or how we are using it in our daily practice. So let's start with the case. 50-year-old gentleman, COPD, obese, AML, undergone bone marrow transplant. Day 5 of BM post bone marrow transplant, patient developed fever, shortness of breath, and desaturation. From chest X-ray and ultrasound, we found that patient has a bilateral basal consolidation. There's the worsening hypoxemia, so we have started on NIV. Patient was very irritable, restless, not complying with NIV, so start desaturating even with 15 liter oxygen. So what is the next option? In a non-immunocompromised scenario, probably we'll intubate this patient, right? In pre-COVID scenario, at least. We usually do not go with non-invasive ventilation when the patient is requiring such an high support. But in immunocompromised patient, this is a difficult decision because of very high chance of VAP. So what are the if you look at the contraindication of NIV, there will be the one most important thing is the alter in the sensorium. If the patient is not responding, if the patient is irritable and uncooperative, or if the patient has a claustrophobia because of that tight fitting mask, there is a high chance of NIV failure. Along with that, if there is a facial injury, facial malformation, or there is a lot of sputum production, if there is a chance of aspiration, again, application of NIV is little complicated. To some extent, all these challenges can be managed when we replace NIV with HFNC. So if you look at the NIV failure rate, it can be immediate, that is within the few hours, early, within the first 24 hours, or late. And most of the failure because of altered sensorium, lack of patient cooperation, irritability, restlessness is mainly in the early phase, immediate phase. So can we replace NIV with HFNC? This is one of the landmark trial called Florelli trial, when they have taken acute hypoxic respiratory failure patient without hypercarbia, PA to FiO2 ratio was less than 300, and they compare the standard oxygen therapy along with HFNC and NIV. So when you look at the overall of the population, overall cumulative incidence of intubation, they found there is no statistical significance between non-invasive ventilation, standard oxygen therapy, or HFNC. But in the subgroup analysis, sorry, in the subgroup analysis, when they pick up more severe cases of hypoxia, that is PaO2 is less than 200, then they found there is a significant advantage of decreased incidence of intubation with high flow nasal cannula compared to NIV on standard oxygen therapy. And when they look at the 90 days mortality, they found that the chances of 90-day survival is high with high flow nasal cannula, maybe because of this decrease in the chances of intubation in severe patients, who will probably dictate the total number of mortalities. Now, what happened? Can we use this HFNC in immunocompromised patients? We all know that in terms of respiratory support, non-invasive ventilation is one of the has a grade 1 recommendation when you are talking about hypoxemia in immunocompromised patients. Now, there are studies, this is systematic review in literature, when they have compared multiple SCTs, when HFNC has been compared with non-invasive ventilation or standard supplemental oxygen therapy. And then, though the result is a little heterogeneous, still they found that in most of the cases, high flow nasal cannula is either comparable or or better or non-inferior to NIV, and in most of the time it is better than supplemental oxygen or standard oxygen therapy. But what about in COPD? As we discussed, our patient has a COPD, so there is some understanding that if you use high flow nasal cannula with such a high oxygen concentration and flow, it may cause increase in the PCO2. Even in our Florelli trial has kept the hypercarbic respiratory failure out of the study as an exclusion criteria. But there are reviews which shown that if you are using HFNC, it is as good as NIV in removing CO2. It can keep PCO2 unmodified. Maybe because of the open mouth, there is a decrease in the oxygenation compared to NIV. The work of breathing reduced by HFNC is similar extent with NIV, which is a very important parameter while we are managing a hypercarbic respiratory failure. And when you're comparing the work of breathing compared to supplemental oxygen, HFNC can decrease the work of breathing by 40 to 50%. And in nearly all the studies have shown that HFNC is more comfortable compared to supplemental oxygen and NIV in terms of management. Now let's see, let our case continue. So what happened next? The patient's oxygen requirement persists. There is a non-significant clinical response even with the broad spectrum antibiotic. We suspect a pneumonia. Patient cannot produce any sputum. Patient is having multiple antibiotics. We like to streamline it. So basically, we need a sample. So we plan for a bronchoalveolar lavage for optimization of the antibiotic. And again, we have to do intervention like that so that we can avoid intubation. How can you go about it? So again, HFNC can play a big role while we are doing in fiber optic bronchoscopy in this type of patients. And there are multiple studies which shown that fiber optic bronchoscopy is done in sick patients with the support of HFNC. It maintains oxygenation better. Patients are more comfortable. They tolerate bronchoscopy better. You can sedate to some extent with the drugs like dexmedetomidine. And the success rate of chance of reintubation during the procedure is comparatively less. Even from Tata Medical Center, our pulmonology department and anesthesia has published one case series when they have used HFNC for EBUS technique in our cancer patients, CA lung patients. Next, but even all these interventions, our patient does not improve. The hypotension, patient develop hypotension. It causes increase in the noradrenaline, persistently increasing lactate, persistent fever. Lung function was reasonably stable with high FiO2. We thought this may be a new onset sepsis, and it may be a primary BSI, or it can be a CLAPSI, or can be idiosepsis. And this patient, because of this worsening clinical condition, hypotension, increasing lactate, probably need to intubate this patient. So again, one patient who is hypoxic, who has requiring high FiO2 requirement, high oxygen requirement, can HFNC help to intubate this patient? So here the concept of pre-oxygenation and apneic oxygenation will come. So whenever we are intubating a critically ill patient, we like to pre-oxygenate them. And what are the modalities we have? It can be a standard bag mask ventilation, high flow nasal cannula, or non-invasive ventilation. And when you look at the applicability of these things, It will be in terms of severity of the disease, whether it's POTFR2 is more than 200 or less than 200, feasibility, training, and availability, and also to the patient's preference. In terms of supplemental oxygen, it was seen that high flow nasal cannula and non-invasive ventilation is much better while maintaining will do a pre-oxygenation when increasing the oxygen status of the patients. It has been measured in terms of PO2, SPO2 during the procedure, also by the end tidal oxygen concentration of these patients. So studies which has compared the face mask with reservoir vac along with high flow nasal cannula and NIV has clearly shown that if you measure the pressure, which will probably eventually help to open up the basal atelectasis of the patients, NIV is better, and HFNC probably can generate up to a pressure of 2 to 8 centimeter of water depending on the flow. If you increase the flow, the pressure will be more. And if the patient has an open mouth, then the pressure will drop in HFNC. In NIV, obviously, it can maintain a pressure, and this pressure will be minimum when you are giving a supplemental oxygen. But if you look at the FiO2, of the oxygen concentration, even with the mouth open or closed, HFNC will do much better compared to NIV or any face mask. And obviously, as the patient basal lung will be recruited with a high flow, so high flow of 45 or 60 liter per minute will give a better oxygenation compared to a low flow state. And when we are talking about patient's comfort, ventilatory comfort or auditory comfort, definitely HFNC has a significant edge compared to the other two interventions, specifically NIV. So what happened during this is about when we are pre-oxygenating patients. What happened during the course of intubation? There is a higher chance of desaturation while using an NIV or we are using a HFNC. Head-to-head studies with HFNC and NIV has shown that the chance of desaturation during the procedure is more or less same in HFNC and NIV. And the take-home message that they conclude, then compared to a standard mask ventilation, pre-oxygenation with HFNC does not improve the lowest SpO2 during intubation. But when you look at the frequency or number of desaturation less than 90% cases, they have found it is significantly low with HFNC compared to NIV, even when the chances of difficult intubation were significantly higher in that HFNC subgroup. When you are talking about difficult intubation, probably the timing or duration of apnea or duration of airway handling was longer, so the chances of desaturation during the procedure was comparatively higher in HFNC compared to the standard bag mask ventilation. But the result has shown that actual incidence was less in HFNC. And at the same time, the severe and moderate complication during the airway management was also significantly less in HFNC compared to NIV. But can we use both modality together? There are studies which used HFNC along with NIV while pre-oxygenating the patients. This is called Optinif trial. What they have done in severely hypoxic patients, they use HFNC to maintain the oxygenation, and along with NIV, they maintain the pressure, tracheal pressure, for better recruitment of the lung. And they have shown that when we are combining HFNC with NIV, there is a significant lesser chance of desaturation or drop in the saturation during the procedure of intubation. And whenever we are using an HFNC, the chances of continuing this oxygen supplementation during the airway handling is also there. That means we can continue HFNC. You can continue HFNC for apneic oxygenation in these patients, which will give an edge over the other airway modalities. But for our patients, the misfortune continues. Patient 2 years after post-transplant, patient develop carcinoma, gastric carcinoma, and probably planning for a gastrectomy. POD3 new onset patient again develop a hypoxemia and desaturation. So probably this is a new onset HAF, vital stable, acceptable work of breathing, but requiring very high oxygen. NIV is not an option because that's an upper airway surgery. So now what? Again, HFNC can play a significant role in post-surgical patients, specifically if we are talking about upper airway surgery where NIV could not be applied. We need to get the mechanism of action of HFNC in preoperative patients and pre-oxygenation, and it probably act by increasing the PEEP and consistently delivering a high FiO2. In apneic oxygenation, the mechanism of splintering of the nasopharynx will come, and along with a CO2 washout, and reduction in the nasopharyngeal dead space. We all know that in every minute there will be around 250 ml of oxygen will be absorbed from the lung into the blood, and the production of carbon dioxide is only 20 ml. So there will be a significant pressure difference between the alveoli to the outside of the dead space ventilation, dead space or anatomical dead space of the lung. So that will cause an automatic gas flow to the lung. Now, if it is the anatomical dead space is already replaced with oxygen, so chances of desaturation will be comparatively less in this type of patients. But when you are using HFNC in the post-extubation period, it will act in a multiple different mechanisms to improve the oxygenation, in like PEEP effect, mechanical splinting of the nasopharynx, CO2 washout, enhanced lung mucosal clearance, as the air delivered is already optimally humidified and warmed. It will reduce the work of breathing, and consistent and high effort will be delivered. All these things will decrease the chances of intubation in this type of patients. So, does this physiological understanding really convert it into an outcome? So, there is a systematic review of meta-analysis which check the usage of high flow nasal cannula with conventional oxygen delivery and with NIV in high risk in post-operative patients. They look at the patients in terms of reintubation rate and also in terms of escalation of any form of airway support. And they have found the overall chance of intubation is comparatively less in HFNC compared to a subconventional oxygen therapy. And which specifically when you are talking about high risk patients, the chances will be comparatively less. When we are talking about high risk patients, we are basically including obese patients and patients who are having a high chance of postoperative pulmonary complications. But if you look at the mortality, it doesn't improve mortality. The chances of the final outcome, mortality, ICU stay, hospital stay, all those things are comparable. For immunocompromised patients to prevent intubation, it has a good scope to use in ICU, specifically in surgical ICU.
Hello.
Hello, I think sir left the room.
Okay, okay. Due to I think some network issues. Okay.
I guess so. Okay. Just let me.
We'll wait for 10 seconds, then maybe we can start the next topic.
Okay.
Okay, I think he has some network issues which is persisting. Yeah. Can I start? Maybe we can start the second talk.
Okay.
He's there.
Yes, yes. Sir, are you audible?
Hello. Yes.
Sir.
Hello. Was it get disconnected in between?
Yes, sir.
Hello. Yes.
Hello, sir.
Hello.
Yes, we can hear you.
Can you hear me?
Yeah, we can hear you.
So it is is it at the end or?
It was last slide only, conclusion only. Yeah.
Okay, then it is fine. So basically, what I regarding conclusion, this is a new modality, at least for the majority of the people, and there is very few institutes which are using it in the pre-COVID era on a regular basis, mostly in the immunocompromised setup. When we are trying to cut down the usage, cut down the incidence of intubation and ventilation, specifically in a post-chemotherapy patient, post-transplant patient, where you are severely immunocompromised and requiring a larger chances of VAP. So, but we need to remember that even in this scenario, though HFNC need a lesser amount of monitoring compared to NIV, it needs a certain amount of monitoring, and we have to identify when there is a failure with this modality and patient need intubation. By HFNC, we should not delay the intubation in a patient who need a more advanced or more stringent respiratory support. So, thank you. I think Dr. Tapas can take it from there.
Okay. Thank you. Okay. Now the screen is visible to everybody. Hello.
Yes, sir, it is visible.
Yes, it is visible.
Okay. Good evening, everybody. Thank you, Fisher and Peckel, for giving me the opportunity today to discuss about something which we day in and day out practice in our clinical practice in COVID time. So my talk will be little bit different than Dr. Sudipta. He has elaborately discussed the usefulness of HFNC in our non-COVID areas where we can use it in a better way. So my talk will be non-invasive respiratory support, how to choose the right modality in the COVID era. So basically it is choosing the right apple, the best apple out of the bucket of apples. So I will be discussing in next 20 minutes about the difficulties with which we face the last year, maybe I will say the ending of the COVID-ridden year. And you can see the picture here. Lot of things have changed in last year. This is the Starbucks picture. Maybe it is good year, bad year. Maybe it is LinkedIn. Now it is locked in. Or maybe it is MasterCard. Or maybe it is the Olympic game sign. So this also has happened to our approach towards the respiratory support, which we normally prefer in our critical care practice. Before, maybe any patient who was coming to our emergency department in a severe respiratory distress, the literature, as per the literature, we normally preferred let's intubate and ventilate, and we know the advantages of putting the patient in rest. We normally preferred for the neuromuscular blocker, give 48 hours of rest, and the patient should improve. But no, this is not the normal time. This is COVID time. And that has actually changed our perspective towards looking at the different respiratory support. And this is the reason why non-invasive respiratory support has taken a leap forward compared to the invasive respiratory support, because there are so many complications that are associated with intubating and mechanical ventilating the patient of COVID. So what is different in COVID? We all know, but I will summarize in one slide. This is the case, this is the disease, the rapidity with which it spread in last maybe 10 months or so, the morbidity and mortality associated with it, and the paucity of the evidence-based management guideline. We know every month, every day, some or other literature is coming up with some guideline, but we do not know that which is the best one. We have so many things, but we do not know which is the best apple to choose from. So that may be one of the concern every clinician is having. This is the disease process that has been categorized like ARDS. But believe me, my friends, the reality, it is not like typical ARDS. So it is not ARDS, rather it is KRDS, CARDS, CARDS. So it is not ARDS, it is CARDS. Lung compliance compared to the normal typical ARDS is normal. But we all have read in our the clinical practice that in ARDS the lung compliance is actually jeopardized, but here the lung compliance is often normal. We have all known the concept of happy hypoxia. I have also seen patients with SpO2 of 30 to 40%. They were sitting in the ICU bed and happily smiling and talking over phone. So that is happy hypoxia concept. So many patients, they are having low SpO2 but not in typical respiratory distress, which we have expected in our normal ARDS patients before. So this is again one difference compared to our normal perception. Then we know that patient treatment is not based solely on a single number, like the pulse oximetry number may not be a reliable marker of respiratory compromise, but we advise every patient of COVID to have a pulse oximetry, maybe in the home or maybe in the hospital, in the monitoring area or in the COVID ICU area or in the isolation ICU. But the real concern, we need to supplement oxygen to these patients. Oxygen is the therapy. But how to give the oxygen is a $1 million question. And that is the concept, that is the essence of our today's talk. Simultaneously, we have to also understand that we have to limit the spread of infection to our fellow healthcare workers and minimize or avoid aerosol generating procedures. That is also coming up in our back of mind, that we do not do any procedure that will increase the aerosol exposure to our own self or to our healthcare workers. So our priorities while managing a patient with COVID, to maintain the SpO2 in the safe range relatively, maybe around 90, 92, 93%, and oxygenation should be our first priority. COVID has taught us, this is very clear, that non-invasive respiratory support is our first priority. Invasive respiratory support should be avoided as much as possible in mild to moderate variety. But yes, in severe variety, when we do not have any other option left, maybe we can go for invasive respiratory support. But in the initial stages, invasive respiratory support should be avoided because of its own complications and limitations. And mild and moderate variety, non-invasive respiratory support. We have seen this picture. I have seen this picture in 4 consecutive days in the newspaper, news channels are in the newspapers. Trump versus Biden, 264 versus 214. So I am again put this picture deliberately, that it's not getting a winner at the end of my talk, that whether it is NIV is the winner or HFNC is the winner in the COVID. It is just getting the best, the result where we can cure our COVID patient. It's not labeling a winner, that whether it is Trump or it is Biden. So we'll compare with standard oxygen therapy or conventional oxygen therapy or HFNC or NIV, and we have to choose it rightly also in the right patient. So let's start with a case. 43-year-old male presents with 1 week of fever, cough, congestion, chest pain, and shortness of breath. Now every person in the road also, they will say it's a COVID. It's not a clinician or like me or like Dr. Sudipta or anybody who will diagnose it. Now everybody is saying test. Let's do the test and let's finalize whether it is COVID or not, and start anti-COVID also without consulting the doctor also. So that is the urgency of the situation now has made everybody a clinician. So this patient presented to us febrile, tachypneic or mildly tachycardic also. But he doesn't look like to be in severe respiratory stress, though his saturation was 77% and his X-ray reveals bilateral infiltrates. So what are your next steps? Does he need intubation? Again, if it is pre-COVID, I could have thought about, okay, let's intubate. But it's not pre-COVID, it is COVID era, which is continuing, and it will continue to 2021 with the recent strain of COVID coronavirus in UK. So does he need intubation? I will say, let's wait, not do the intubation right now. I will first manage the case in a negative pressure room if possible. First one, first come first. These patients should wear a mask while receiving any supplemental oxygen, whether it is COT, conventional oxygen, whether it is HFNC, whether it is venturi mask, whether it is face mask, whatever. But this preferably should wear a mask to reduce the aerosol generation. If this is not possible, maybe we can use a private room with a closed door. But providers must take airborne, droplet and contact precautions. Now, let's assess the patient. We cannot just rely on the number 77. It's just a number for me in COVID. A better way to determine the disease severity is to look at how the patient looks like, how he is behaving, whether he's confused, whether he's drowsy, whether he's not maintaining his airway, rather than only just 77 number. Now, we all know the difference between L type, H type. As per the Gattinoni's concept, we all start with the L type, which is the most commonly presentation in the COVID, which is the normal lung compliance. It is the L for low elastance, high compliance, which is the almost 77% of COVID patients present with L type of the ARDS. And for these patients, oxygen is the key, not intubation. So let's clear this concept in the first patient assessment itself. So most patients, 77 out of 100 patients, they will 70 out of 100 patients, they will be treated with oxygen, not with intubating. Now, there will be 30 out of 100 patients, they will be presented little bit later on, maybe advanced form, and that will be H type. H for high elastance, low compliance, and that will be typically resembling our pre-corona, that is the ARD, typical ARDS pattern. And in these patients, maybe intubating, putting on high P, recruitment maneuvers, proning, all these things will be helpful. But we'll be dealing more or less with 70%, that is the L type of ARDS in our COVID patients. And for these patients, supplemental oxygen with non-invasive respiratory support with goal of SpO2 more than equal to 88 to 92% and reducing their work of breathing, giving some assurance, motivation is the essence, is the key that we have to understand very clearly. So what are the options in front of us right now? I'm confused. I am a clinician. I am in the emergency department or I am in the COVID ICU. The patient has come with 77% saturation and I have a plethora of options right now in front of me. That is simple oxygen therapy, which includes nasal cannula, simple face mask, venturi mask, non-breathing bag and valve mask. Then there is also presence of BiPAP or CPAP with face mask and also recent one which is a helmet NIV. There is also another machine in my COVID ICU, that is HFNC, and I also know the pros and minus of awake proning. So how to actually combine all these things or how to choose the right one for my patient and make the patient better. Let's understand the prerequisites first. Then only we'll go for opting the non-invasive respiratory support. The prerequisite is, first we have to understand the patient comfort level. How we are comfortable in putting that NIV or non-invasive respiratory support or HFN in our patient. If we do not know the concept, the machine itself, we do not understand how to put that in our patient, there is no use of all these fancy machines in our ICU or in our critical care areas. And also, we need to monitor the patient second to second. It's not putting that HFNC machine and forgetting about the patient and doing our own work. No, this is not done. Now, technical aspects based on reducing the aerosol generation and exposure. Maybe the things look a little bit attractive to me, but I have to understand also by that how much aerosol generation is happening to my fellow healthcare workers. Then only I have to decide whether it is advisable in my ICU or not. The second point. Third point, I need to understand the disease. It's not all about the monitors and the machines. I have to understand the disease. Fourth one, let's make it very clear, not one size fits all. I cannot say that HFNC is the answer or NIV is the answer. I have to be flexible in my decision making if I am getting wrong results from my patients after putting something on the patient itself. So it has to be very flexible decision. Now, how to escalate my oxygen strategy? We have understood this, we know it, we are doing it. I'm just putting it in a picture, in a snapshot itself. I will start with maybe nasal cannula at 6 liters per minute. Then I will go ahead with venturi mask, which can give the oxygen maybe up to 50% to 60%. Maybe I can combine this nasal cannula with the non-repeating mask. That is the third option for me, which can give maybe the oxygen to FiO2 to almost 80%, maybe 90%, something like that. Fourth one maybe in the ladder is HFNC for me. And HFNC I can do it along with awake proning also. All these things can be combined with awake proning. Fifth one, if the patient is not responding to HFNC, getting drowsy and the work of breathing is very high, then maybe before intubation I can try with small exposure to the non-invasive ventilation or NIV. And finally, if everything fails, I can go ahead with intubating the patient. That is the golden rule. But at each step, look at the patient. If the patient is not improving or feeling worse, then move to the next step. And at each point in the escalation, you can use the patient repositioning or proning. That is going to help you along with this oxygen exhalation strategy. Now, coming to the risk of aerosolization, comparison between all the available options in front of us. You can see here, HFNO, which we are using regularly, is hardly, you can see, 15 centimeter. Up to 15 centimeter is the distance to which the aerosol can be dispersed. Compared to NIPBV, which is non-invasive positive pressure ventilation, it can go up to 100 centimeter or 1 meter. So the chances of healthcare workers getting the exposure from the patient is very high with non-invasive positive pressure ventilation, which is the NIV. Almost similar to the nebulizers, but it will reduce compared to the NIV, to the HFNO, and the minimum will be non-rebreathing mask. Now, simple oxygen therapies, I have already discussed. This is just for the drainage. They can know nasal cannulae going up to 2 to 6 liters. The dispersion of exhaled air can go up to 40 centimeter. Venturi mask, again, 20 to 60%. You can also add the oxygen as per our flow rates, and the dispersal again can reach up to 40 centimeter like the nasal cannula. But you can wear the surgical mask over the nasal cannula as well as the venturi mask. Now, non-rebreathing mask, oxygen can go up to 15 liters per minute, and the reservoir bag has to inflate it to prevent the hypercapnia, which is the concept behind the non-breathing mask, which typically needs the flow rate over 8 liters per minute, and dispersal is less than 10 centimeter at 10 liters per minute. This is the lowest one, dispersal. And again, cover the patient with face mask. Then you can combine nasal cannula with non-rebreathing mask. And now coming to the HFNC, I have made a very good synonym, or you can remember it very well. High flow. H, the advantages already described by Dr. Sudipta. H for heated and humidified. I for inspiratory demand. It will provide, or it can better meet the elevated peak inspiratory flow demand. F for functional residual capacity. HFNC increases the FRC by delivery of PEEP. Then L, it is a lighter modality of non-invasive respiratory support, so better tolerated than the CPAP or BiPAP machine, and it can also dilute the oxygen by meeting the flow demand of the patient. And also in the end, W, that is wash out of the dead space. So it also improves the carbon dioxide removal by providing high flow rate. So HFNC advantages are high flow. Now, in COVID time, studies have evaluated the hypoxic patient in COVID-19 as well as other disease states. They have seen that there is reduction in the mortality and also need for intubation and ICU admission in these patients. WHO and Society of Critical Care Medicine from US, they have preferred HFNC over NIPBV in patients with COVID-19 and acute hypoxemic respiratory failure. Initially, there was concern of aerosolization, but later on, it has not been demonstrated in the literature. But patients should preferably be in a negative pressure room, if possible, with the staff definitely wearing airborne precautions and mask over the patient. But one important thing I want to highlight here, you have to maintain the circuit temperature. Otherwise, what will happen? The condensation amount will be increased, and that will be a source of infection for the COVID-19 patients. So you have to maintain the circuit and temperature, and as well as when the ambient temperature, and you have to also avoid the condensation in the HFNC patients. Few tips already discussed. You have to maintain in negative pressure room, but start oxygen flow from 20 to 30 liter. Do not start with 60 liter. It will be very discomfortable to the patient. Patient will start with cough, which may be intolerable in some patients. So maybe you can increase the FiO2 to 100%, but flow to be increased gradually as the patient is actually comfortable to the HFNC. While you are adjusting the nasal cannula, you have to turn up the flow when you are adjusting the nasal cannula. Otherwise, what will happen? You will be exposed to the aerosols. So that is 2-3 tips I want to highlight. And use snug fitting nasal cannula. Do not have the very loose or very light, which is not appropriate for the patient. Physiology comparison with NIV, it is actually a flow generator, while NIV is a pressure targeted modality. And this is compared to the NIV. NIV is actually responsible for success in COPD and CHF because of its pressure targeted modality. But HFNC is actually beneficial to the patients by its high flow that indirectly reduces the dead space to improve the ventilatory efficiency. This is the article already described by Dr. Sudipta, Floralita trial. They have compared HFNC with non-rebreathing bag with BiPAP, and they are straightforward. They have got the result. The intubation rate was actually less in HFNC. It is 38% compared to non-rebreathing bag, 47%, BiPAP 50%. While secondary outcome was ICU mortality, it was lowest, which is 11% in HFNC, while it is 19% in non-rebreathing bag, and it is 25% in BiPAP. While 90-day mortality and ventilator-free days also were more preferable to the HFNC. So this is the in the result in the gist. It decreases the mortality, decreases the intubation, decreases the compared to the NIV and NRV in the acute hypoxemic respiratory failure. So how to set HFNC in COVID patients? Start with 100% FiO2, already described. Start with the flow rate of 20 to 30 liter per minute and titrate up to maximum of 60 liter per minute if needed. But you have to see the patient's comfort level, because higher the rate, maybe it will not be comfortable to the patient. But keep in mind, this is the normal opposite what we normally do. We start with high flow and we gradually increase the FiO2. We need to understand one index, that is ROX index, that will actually give you the idea which patients you want to continue with HFNC, which patients are actually the category where you need to step in and discuss or decide about putting the patient on NIV or the final intubation and mechanical ventilation. This is performed at 2 hours, 6 hours and 12 hours. But it should not replace our clinical assessment. What is ROX index? ROX index is actually the ratio between SpO2 divided by FiO2 divided by respiratory rate. And in simple terms, I will give you some numerical values here. At 6 hours, my patient saturation is 88%. So SpO2 is 88. FiO2 is 70% or 0.7. So I can divide it to 88 divided by 0.7. And the respiratory rate at that time, after 6 hours of putting the patient on HFNC, is 28. So 88 divided by 0.7 whole divided by 28, which comes to 4.48. And as per the literature, they have found if at the 6 hours, less than 3.47, then definitely you should remove the HFNC, put the patient on NIV or decide about final intubation. So my patient's ROX index is right now 4.48. Maybe there is time I should continue 2 or 3 hours. So this is the essence of ROX index in COVID patient. NIV, few slides about NIV. This is the final step in escalation before intubation. We know the two forms of NIV, CPAP or BiPAP. BiPAP, normally we are more conversant with the facial mask. Definitely, we do not have this much of resource in our Indian setup. Helmet devices are very rarely used in our Indian ICUs, but maybe it will come in near future. Then we see how it stands against HFNC. Helmet NIV versus HFNC in COVID patients. SCCM recommends against NIVV unless HFNC is not available. This is very clear. But NIVV has been used with success in few countries like China, Italy, and Newer. But important point about NIV, which is a disadvantage, NIV role in self-inflicted lung injury. Patient self-inflicted lung injury, in short, PCL. and the risk of impacting in a change in ARDS phenotype from L type to H type. That means if you are not judiciously using or right patient, you are not using NIV, maybe you are inducing more injury in that patient, and the patient from the milder variety of ARDS is going into severe variety of ARDS. That means L type ARDS to H type ARDS, the probability of converting into H type ARDS is more if not properly managed with good non-rheumatic respiratory support. We need to understand, we need to monitor the expiratory tidal volume in these patients, and also we need to also look into unintentional leaks while using NIV, because that will be one of the drawback of putting the patient on NIV. Higher VTE more than equal to 9.5 ml per liter for consecutive 4 hours is independently associated with NIV failure. That is one of the literature that we need to understand. But we also need to analyze how much patient is on NIV versus HFNC before putting the patient on invasive mechanical ventilation. Specific mode, which is better, it's still debatable and controversial, but we need to understand that CPAP can be useful when the patient along with COVID is also associated with cardiac pathology or obstructive pathology. In that case, BiPAP, the inherent positive point about BiPAP will be more useful in those patients. Must do in COVID patients for NIPBB, we need to attach the viral filter correctly before connecting to other things like end-tidal, bag valve mask, ventilator. We need to also ensure that there is no leak in the circuit. And also you can start with FiO2 100%, start with PEEP of 5, then you can go ahead depending on the patient's response and SpO2. And ABG will be helpful in titrating your settings as needed. But remember this, do not go above PEEP of 20 in NIV. That will be a disastrous, and you have need to intubate the patient in real emergency. Rather, put the patient on mechanical ventilation electively at that time. Make sure you are using NIPBB in a closed system. Otherwise, you will be blowing COVID everywhere in your hospital, in your ICU, and in your healthcare workers. Already discussed, there are some advantages of NIV with helmet surfaces because it will be more comfortable to the patient. You can scavenge or filter the exhausted gas in a better way. There will be less air leak compared to the face mask interface, and also that will be you can also give higher level of PEEP to your patient in helmet PEEP, helmet NIV, and this will be this will be more comfortable in those patients. But it will be testing against the time, how it will be performing when we are having proven HFNC. And this will be the circuit look like non-vented full base mask. There should not be any non-invasive strategy. And in patients who will be more responsive to the HFNC will be patients not responsive to the PEEP, because it will be the early form of ARDS. That is, those patients may be use of awake repositioning. I have already told, in intubated patients it has been shown, but in non-intubated patients the literature has been silent till now. But yes, few small case series they have actually come in recent literature, and they have shown in COVID patient, if you are going for awake repositioning or awake proning, maybe the PaO to FiO2 ratio go up to 35 millimeter mercury, and the mortality will be reduced in moderate to severe ARDS patients. This is the HFNC or NIV in severe ARDS patients. This is already discussed by Dr. Sudipta. And this is again in June 2020, this systematic review and meta-analysis come, which he is comparing all the non-invasive oxygenation strategy with the all-cause mortality in adults with acute hypoxemic respiratory failure. And you can see here that the mortality rate is definitely lesser compared to the mechanical ventilated patients. They have compared helmet non-invasive ventilation, face mask non-invasive ventilation, high flow nasal oxygen, as well as the normal oxygen 25 randomized control trials they have taken, and they have found mortality rate is definitely less compared to the invasive respiratory support. What are the potential strategies and perspectives in current scenario? Options are definitely differing between different scientific societies, countries, and different environmental factors. I cannot equate one ICU in US with one ICU in India because of lack of facilities. ICU beds are different, experienced personnel are different in different ICUs, and equipments may have a role in selecting right therapy and ultimately having impact in the clinical outcome. But these are the scientific society and their preference, non-invasive respiratory therapy. And you can see here clearly HFNC till now is the winner. I will not say it finally will be the winner, but yes, definitely right now at this moment, at this juncture, maybe I will say HFNC should be the preferred non-invasive respiratory support in COVID-19 patients in mild to moderate variety. So let's sum up. PPE should be the initial consideration when managing any patients with COVID-19. Use of HFNC, NIV, as it was previously thought, the risk of droplet exposure is not at all significant, so we can easily and safely use HFNC in proper way. Use of HFNC at a flow rate of 40 liters per minute with a surgical face mask in place over the patient's mouth and nose shows no greater dispersal of particles than low flow oxygen with a face mask in place, so it is very safe. Awake proning is feasible and may stave off the early intubation concept. Patients come in 3 flavors to my ICU. I will now give one flow chart for my trainees. Silent hypoxemia, they will not need any intubation. Trial of spontaneous or standard oxygen therapy, NIV, HFNC with awake proning will do the trick. Intermediate hypoxia, they may need, but I need to be very optimistic and I need to combine all this non-invasive support in a proper way along with anti-COVID management. Respiratory distress patient, they will need intubation. Definitely they have gone too far for the NIV or CPAP, but definitely first start with the nasal cannula and surgical mask. Target should be SpO2 88 to 92%. If this fails, go ahead with HFNC, put a surgical mask over your patient's face, awake prone the patient, calculate the ROC score. If it is less than 4.88 at 6 hours, consider intubation. If the patient is not going for the HFNC, maybe you can give a trial of CPAP plus awake prone position before intubating. And finally, these are the flow chart which will start with non-breathing bath plus nasal cannula. There are 2 options, HFNC and non-invasive positive pressure ventilation along with proning, and finally intubation. So take home message from my lecture: one size fits all approach to this acute hypoxemic respiratory failure is a misguided concept. Choosing the right non-invasive oxygen support, if somebody will ask me, I will say I will go ahead with precision-based approach that will be more towards the observed phenotype of this ARDS. If it is L type, I will give something. If it is H type or advanced form, maybe I will go ahead with the intubation or NIV. And this will depend upon the patient's clinical experience and comfort with which in last maybe 9 months, 6 months, or 1 year or so. Winner per se, my focus is not at all to declare a winner, but rather on identifying the patient phenotype that stand to benefit from my non-invasive oxygen support. Finally, my patient should improve, my machine should not win. In the management of the heterozygous syndrome like this ARDS, COVID ARDS, it is better to have multiple options in my ICU or my armamentarium rather than focusing on a single choice where I may struggle. And my thoughts at the end, given the current circumstances, I don't think there will be any RCT in near future to confirm which non-invasive respiratory support is the winner before going for the intubation. Manufacturers, like all these advanced companies, maybe Fisher-Paykel should think about it. They should be urging to create safer interface, viral circuitry, and new generation non-invasive ventilators with integration of different therapy. Maybe some specific monitoring should be there, and also there should be necessary safety features. And this will be definitely a marathon, not a sprint. And I know we all know the concept, the story of David with Goliath. And finally, we should win over the COVID pandemic, not the COVID pandemic will win over our expertise, our experience. Thank you all. And maybe now we are going for the second wave, third wave of COVID-19. And I recently got this interesting, the article, the topic that yes, they have a new approach, that is high flow nasal cannula. The complexity of the disease has made ventilator use really challenging. Thank you all. I am open to any questions from you. Thank you. Sudipta, your voice is not audible.
The audio is turned off.
Hello.
Yeah.
Hello.
Yeah, now you're audible.
Okay. So I have received one question regarding my presentation, that what is the role of combining HFNC with awake proning. Now in COVID area, we all know that we are going with awake proning to decrease the chances of intubation, and we are sometimes combining HFNC or NIV with awake proning also. But in a pre-COVID era, I don't know any data or any literature which suggests awake proning in hypoxic respiratory failure patients. This concept of awake proning has developed in the COVID era due to decrease the number of intubation, to decrease the chances of to prevent but manage this patient in a non-intubated scenario or with a non-invasive respiratory support. So HFNC, yes, but combining HFNC with awake proning probably something related to COVID.
In simpler words, necessity is the mother of invention. So when we struggled with COVID, something need to be done before intubation, and we started with awake proning.
So any other question, if we can put it in the chat box.
I think the message was very clear that definitely we need to be expert in handling all these non-invasive respiratory support, and moreover, HFNC has stood over the time in last 9 months or maybe more than that, last year. And definitely we need to see maybe that there will be change in the viral strain, how the patients will come, and in that case, how the HFNC or all these non-invasive respiratory support will actually cope with. What do you think, Sudipta?
Yes, I agree. I fully agreed. And as Dr. Tapas mentioned, probably we are looking at a precision-based medicine, and we cannot decide beforehand which non-invasive interface we are going to use. We have to decide on a patient-to-patient basis, and we should not be reluctant or should not hesitate to change from one modality to another when we find that it is not working. So we put on someone on HFNC, and now the patient is not improving by the ROS score. We should be able to shift either to NIV or to intubation and ventilation. And another question we have seen in the chat box regarding fixed and variable performance oxygen therapy. So fixed and variable performance oxygen therapy depending on whether we can deliver a fixed oxygen concentration to the patient. Now, oxygen concentration to the patient depends on any form of devices. Depends on, one is the oxygen flow, another is the patient's inspiratory effort. Now, if the patient's inspiratory flow is more than the oxygen flow, oxygen delivery, then obviously there will be entrainment of air from the surrounding, and the oxygen concentration will be a variable factor. We cannot control it. There are modalities where we can deliver a fixed oxygen concentration irrespective of the patient's respiratory effort or patient's respiratory flow. One of these HFNC, one is high flow mask, one is NIV. Another modality will be high flow mask with a reservoir bag. When if patient has a high inspiratory flow, the excess oxygen will come from the reservoir bag. Same thing from a bag mask during bag mask ventilation. If you put a bag mask ventilation mask with a reservoir and patient is continuously breathing, the excess oxygen or excess flow will be managed to the reservoir bag. But that is not applicable in a variable performance oxygen therapy. Anything, Dr. Tapas, you like to add?
Yeah, I got a question from Miss Manorama Parida. And her question is precautions during use of HFNO. Yeah. So already I described in my lecture, there was a slide that again, yeah, there is a chance of aerosol generation during this procedure or during this non-invasive respiratory support. So you need to be very cautious while putting. You have to turn up the flow while you are changing the nasal cannula, and also you have to use snugly fitting nasal cannula. There should not be any leak or like size doesn't like not fit your nasal cannula. The nostril is big and you are putting a very small nasal cannula, that the chance of aerosol generation is more. So these are the precautions, and again you have to use surgical mask over the HFNC. So that has been proven. The literature has come up the idea that if you are using HFNC and then putting a surgical mask, there is no chance of hypercapnia, rather than the CO2 is less when you are putting the surgical mask. Yeah.
And Dr. Irfan has asked regarding what is the performance of oxygen therapy devices. Performance means whether you can deliver oxygen in a predictable manner. So suppose I want to give 60% oxygen, can I deliver 60% oxygen in an accurate, predictable manner to this patient? So if I suppose for a mask, when you put a simple face mask, we started with a 10 liter or 12 liter oxygen, we can predict the delivery of oxygen probably will be 40 to 60%. And it will vary depending on the patient's inspiratory flow. If the patient has a less inspiratory flow, the FIO2 they get delivered will be higher. If the inspiratory flow is high, the patient is very tachypneic, which happen in a severely sick patient, then obviously there is large amount of entrapment of air from the surrounding, and the FIO2 will decrease. So these are variable performance devices where the FIO2 will fluctuate depending on the surrounding factor. But this doesn't happen with a HFNC. It doesn't happen with a face mask with a reservoir bag with a venturi mask, where the delivery of oxygen is fixed and predictable. You can measure it. You can know that yes, I am giving 40% oxygen. Now patient is deteriorating, is desaturating. I need a higher oxygen. So that you can know and you can utilize it as a to follow up your patients. I think I am clear.
Any other questions from any of the
Regarding the humidification, I think the recommendation is for the distilled water. Whether you can use normal saline or not, I am not sure. But the problem will happen with the rather than the fluid, it will be the bag. That bag have to the bottle have to be self collapsible. If it is not, after a certain time there will be a pressure difference and there will be no water going into a humidifier, and it will not work. So the pouch or bag you are using, you have to be standard and it have to be self collapsible.
Finally, it is also the training to your nurses, your paramedics, your junior doctors need to be very well versed with any of the machines, any of the equipments they are using during this COVID pandemic or during the non-COVID also time, rather than putting a label that okay, if this is successful in ICU, rather than we can have a proper expertise of all these machines, then we'll get definitely benefit. Okay, I think anybody from the Fisher and Paykel who wants to summarize or give some message?
Also, there is another question from Irfan Atlaf.
Yes, you can see that's regarding the Venturi mask. Now, for Venturi mask, the entrainment ratio doesn't apply because Venturi mask has a fixed oxygen concentration, right? So we depending on the FiO2, you put a connector which has a small hole. Through that, oxygen, atmospheric air enter, and eventually you achieve a certain concentration. That's why depending on your targeted FiO2, there is also a fixed oxygen flow you need to give. So suppose you want to give 40% oxygen, the oxygen flow which is required is documented or written on the connector, that you need 15 liter oxygen or you need 10 liter oxygen. So regarding the entrainment ratio is fixed with every connector. It will vary when it is not a fixed performance devices like a face mask. When patient is having deep breath, then the oxygen entrainment will increase and it will dilute the oxygen and the FiO2 will fall. The patient doesn't have a high respiratory effort and inspiratory flow, then obviously the oxygen concentration will be more. So that is more applicable for variable performance devices. For a fixed performance devices, the entrainment ratio is fixed in Venturi mask. And if you talk about usage, the usage in practical life is not that much. In the conventional use of Venturi mask was for COPD patients, when you used to target a lower saturation of 1992, and then you use the Venturi mask and can give them a minimum oxygen. And presently, you can titrate that with a SpO2 saturation, right? You can give with a HF mask or nasal prong, and you can decrease the oxygen supplementation till the saturation is around 90. So presently, in my practice, at least, I'm not using Venturi mask to that extent.
Totally agreed. Venturi mask is only for maybe theoretical purpose in COPD patients, where you are actually targeting your oxygen to be very precise, and it has to be not exceeding this much of amount. But in clinical proper sense, this is not of major use in our current clinical practice. Okay, I think we can conclude.
Yeah, I think.
Okay. Thank you all, and wish you all a Merry Christmas in advance, and also Happy New Year. And we hope it will be COVID-free at least. Okay.
Thank you, everybody.
Thank you all. Thank you, Fisher and Pekel,
Thank you
for arranging such a very interactive session towards the end of this year.